All right. Welcome, everybody. Happy Tuesday. Welcome to those of you who might be joining us for the first time. We have a few first timers, I think, today who registered this week. And welcome back to those of you that have been attending the sessions this year. We, as you know, have wanted to take the opportunity in these sessions to revisit core concepts in O&P education and share how we currently approach teaching these topics here at Baylor College of Medicine. So as a reminder, we sent out a survey at the end of last year to gauge where there were the biggest perceived academic practice gaps. And those surveys have informed the discussions that we've shared in the sessions this year. We really want the sessions to be interactive. So we hope that you'll share your thoughts on how your clinical practice either differs or aligns with what you're hearing from our perspective from the classroom. So a little bit of housekeeping before we start today. Everyone here should have received yesterday in the reminder email, and then for previous sessions, the link to the post-session survey and the folder where the recordings are posted. Please make sure that you take that survey within 30 days. If you take it after that, you're more than welcome to do so, but you won't receive credit from ABC for CEUs. If you're not able to attend a future session live, likewise, you can hop in the folder and watch the recording and take the quiz. Just make sure it's within 30 days of the original date of the session. And then finally, we've noted this in the reminder emails, and we will probably communicate with you at least twice, but we are shifting to Teams for the remainder of the CPD session. So this will be our last Zoom session, and all future sessions will be on Teams, and we will send that link out to you ahead of our July session. All right, with that, I'm very happy to introduce our speaker for the day. Sally Kenworthy is an assistant professor here at Baylor College of Medicine, and she has taught our lower limb orthotics 1 course since 2016. She has since received her doctorate, and so I should have introduced her as such, sorry. Dr. Kenworthy. She also teaches our Biomechanics 1 and 2 in our Health Research Methods coursework. As many of you know, Sally is very passionate and very skilled at lower limb orthotics, and I look forward to her presentation and the discussion today. So Sally, take it away.
Ashley. So I had a little intro here, which I'll get to, but what I'm hoping to do to work through with y'all today is to describe different topics that are covered in the master's program curriculum, specifically within lower limb orthotics 1. What that means is lower limb orthotics 1 covers everything from the AFO level below, and then we have lower limb orthotics 2, which covers KAFOs and above. And then hopefully today we'll compare clinical practice to the content taught in the classroom. So I'm going to teach you guys what I teach in the classroom. I have my own clinical experience, but where I'm hoping you all feel totally comfortable engaging with me is sort of what are the differences between literally how you practice and what we have to teach in the classroom. And hopefully we can figure out a way to sort of speak each other's language and improve sort of what the learners are experiencing during residency. And then just as a basic informational thing, show you guys what the educational standards are and then how the current curriculum aligns with contemporary practice, because we do try our best to align it with contemporary practice. I just said to Ashley the other day, I said it's so hard to cover everything that we work through in 45 minutes with a group of people. So this is not a comprehensive session. We won't cover all of the content today that we cover in our lower limb orthotics courses, but it is meant to start a conversation. So I graduated from Texas A&M with my bachelor's in science of kinesiology. I went to O&P school at UT Southwestern and did my residency and all of my clinical practice at Hanger Clinic in Houston. While I was there, I worked with Texas Children's Hospital PTs and OTs, and also at a Tier Rehabilitation Hospital here also with PTs and OTs. So it was all orthotics and I loved it. And it was quite the transition from doing almost all pediatric to all adult care. But what I learned was that there was actually a lot more overlap than I had anticipated. From the beginning, I was trained to tune and align orthoses. So in that office, that was our standard of care. So I had to do some adjusting when I was working with different referral sources and stuff like that that weren't necessarily wanting or understanding what that process looked like. And I bring that up to say I feel like it has helped me become a better communicator in terms of my thought processes and, unbeknownst to me, that actually prepared me well to be a teacher. As Ashley said, I started at Baylor in 2016, recently got my PhD in kinesiology, and I'm excited to have you all here today. I wanted to start off by talking about transitioning from clinician to educator because it was an eye-opening experience for me. And I think even if you're not in the classroom setting and formally teaching people, if you're teaching young clinicians or mentoring anybody, you are an educator. You might not initially view yourself as educator with a capital E, um, but you are an educator and you're a vital part of our O&P profession. When I started teaching, and what I think sometimes, even as a residency, as a resident mentor before I got to Baylor, it is hard to remember what it's like to start at ground zero in terms of your knowledge base. I remember one of my first times teaching lower limb orthotics one, I said, kids with SMOs, and the students were like, we don't know what an SMO is. And I was like, oh, that is my job to teach you literally everything from the start. I also had some challenges depicting and describing subjective terminology. So after you've seen thousands of patients over several years, you have a picture of really what mild is and really what severe is and everything in between. But when you don't have that context of thousands of patients, as an educator, it can be kind of hard. A student might think something is severe, but because I've seen much worse, I know that this is really moderate and it doesn't require such an aggressive treatment. I also had to resist the urge to teach exactly what I practice, because especially in the Baylor program, but if you're preparing a student to go to any type of residency where you learn from multiple people, which is most residencies, um, I couldn't just teach exactly what I do because not every CPO agrees with my clinical approach necessarily. So trying to teach stuff that was universal enough for a student to successfully learn from all different approaches, successful approaches, to clinical care was also quite a challenge, but I think over the years I've gotten there. I also had difficulty creating cases with one-ish correct answer. And we'll get a little bit more into that when we talk about how we test clinical reasoning. And then also, it was difficult to impart upon students how to consider real world factors that they haven't experienced in their real world. Um, even if we just verbally talk to them about the difficulties navigating insurance or navigating like parental disputes, there's only so much you can impart on someone before they are in the situation themselves. So these were some of the things that I viewed as a gap that I had to bridge in order to be an effective educator. So in the Baylor program, we have to meet all master's standards competencies within the first 12 months of the program. That's how we're accredited. And so a couple of the ones, there's a lot of competencies that we have to achieve, but I pulled out just a couple of sections of the standards to go over with you guys today. C.9.1 is comprehension and evaluation. Graduates will demonstrate understanding of foundational knowledge in prescription recommendation, orthotic and prosthetic design, material selection, biomechanical principles, fitting, evaluation, adjustment, and patient-specific outcomes for AFOs, including all of the ones listed there. So as you might imagine, the course for lower limb orthotics 1 goes over, I think probably 4-ish months or so. So we do this deliberately and very thoughtfully because it's a lot to cover. So that's one of the competencies I wanted to share. And then alongside that is the fabrication side of everything. So each graduate will demonstrate skill and experience in the evaluation, recommendation, implementation, material selection, application of biomechanical principles, fitting, adjustment, troubleshooting, and evaluation of patient outcomes with the following custom fabricated orthoses. So alongside all of the didactic or classroom learning, there's the fabrication side of things, which we definitely tie into the curriculum. They have to make a minimum of 2 thermoplastic AFOs. We end up doing 3. We do one articulated and two solid AFOs. One of those solid AFOs is an introductory project where they make it for themselves, but their other two projects, they evaluate, cast, and fabricate custom orthoses for our patient models. And our patient models have real impairments and orthotic needs. So they get to apply what we learn in the classroom directly to someone who needs an orthosis. So before they get to me, a lot of work has been done by other faculty to prepare them for my class. Students have a foundation of normal gait biomechanics, which is taught by me. We just look at normal biomechanics for several weeks. They learn movements of the foot and ankle in their physical exam class and their pedorthics class. They learn assessment of the foot and ankle in both of those classes, and then they also learn pedorthic management of the foot and ankle through shoe modifications, foot orthoses, and UCBLs. So my class is building directly on the content that they receive from their previous courses. They're also enrolled in a class called Pathophysiology, where they learn the pathophysiology of different diagnoses and sort of the underlying mechanisms of different conditions and disease states. And in my class, what we do is go over the clinical considerations. So in pathophysiology, they might learn the mechanism of multiple sclerosis. And in my class, we'll talk about typical gait patterns, what are characteristic aspects of multiple sclerosis that you might be likely to see in our O&P clinics. We talk about the prognosis and then also complementary treatments so that our students are well versed in sort of everyone who might be working with different patients. So after our students learn normal gait, for me, that's really the foundation of where we start to talk about orthotic intervention. Again, this is a very deliberate, carefully laid out order of operations. There's an entire course dedicated to learning normal gait and just what should typically be happening with the muscles and range of motion, et cetera. And then pathological gait is taught in my class in accordance with Jacqueline Perry principles. And then I also kind of make it a hybrid with Elaine Owen approaches to segmental kinematics. They don't generally disagree with each other. It's just a different way to look at pathological gait. And the reason that I do this is that I feel it creates a strong foundation to build clinical reasoning. So kind of at the peak of this class is not just the ability to fabricate orthoses, but for the students to be able to demonstrate that they can clinically reason through a patient presentation with pathological gait analysis, physical exam assessment, medical history, et cetera, and come up with an orthotic prescription recommendation. And, I think it's important to consider clinical reasoning as its own skill, and it's something that can be acquired and developed. And so there are a lot of different definitions of clinical reasoning, but the one that I pulled for today, which I think we'll all be able to relate to, is the one that's here on the slide. For the present commentary, we can describe the clinical reasoning process as including the physician's integration of her own biomedical and clinical knowledge with initial patient information to form a case representation of the problem. The physician uses this problem representation to guide the acquisition of additional information, and then on the basis of that additional information, revises the problem representation. She repeats the information gathering, representation, revision cycle until she reaches a threshold of confidence in that representation to support a final diagnosis or management actions. That's a really fancy way to describe what you all do day in and day out. I never really thought of, making clinical decisions as such a formal process. And that's because it hadn't really been formalized in my head for me at the time. But a model under which, and there are a lot of different learning models, but there's a Dreyfus model of skill acquisition that I have here. And you can see that, there's a novice at the bottom, and that's described as a practitioner who has a rigid adherence to rules. So I have these rules and I'm going to follow them, and they don't exercise discretionary judgment. Part of the reason that they don't exercise that discretionary judgment is because they don't necessarily have all the context that's needed to sort of bend the rules and understand what happens if I do bend them and when can I move outside of them, etc. And so, as you can see, if you move up this Dreyfus model through advanced beginner, competent, proficient, and expert, sort of how you manage the information and problem representation changes as you reach that very top part. So this is kind of an easy question, but I want to know where you all think the first year students lie on this scale. And you can unmute yourself, you can put it in the chat, whatever you want. So what I'm talking about is not necessarily a resident, but someone who is in O&P school for the first time. Most O&P schools will require shadowing or observation hours, so they've at least seen some O&P offices.
Novice for sure.
Thank you. Who was that? Was that Garrett? Thank you. Um, didn't quite recognize the voice. Okay, and so then the follow-up question is, I want to know, where do you all think most mentors or preceptors fall on the Dreyfus model of skill acquisition? We can eliminate novice. Um, but a clinical mentor should be at minimum competent, if not most likely proficient or an actual expert in their area of clinical practice. So what's left is, we have students starting in the novice area. During residency, we're hoping they become competent, right? That's the goal of the clinical education. So as first year educators, as student educators, we're trying to move them through this novice foundation on the pyramid. And you can see that it's very wide. We have a lot to cover just to even get them to have a strong foundation. And hopefully during that first year, we can definitely, move them from novice to advanced beginner and hopefully start to develop their situational perception where we can. But we'll revisit this model, but I just want you guys to keep it. Oh, I didn't see all the chat stuff. You guys have been participating. Thank you so much. If they work in my office, that preceptor is going to be an expert. I love it. Yeah, proficient and expert. Yeah. Thank you guys. I'll keep the chat a little more visible on my screen here. Okay. So teaching clinical reasoning, the way that I approach it is I give everything a biomechanical foundation where possible. It just gives them something sound to start from because biomechanics and ground reaction forces, unless there is some catastrophic event, it should all stay consistent. So we spend a lot of time on gait analysis. We practice watching lots of videos. Tell me what you see. They have to tell us gait deviations in a very systematic way and also use their physical exam findings to then determine the underlying cause of those gait deviations. And so this is also under the assumption that, the big assumption that we are designing an orthosis to optimize gait function. And I know that there's other purposes for orthoses, but for clinical reasoning in this context, I'm choosing to make that assumption here. So they have to be able to identify the problem, figure out what's the most likely underlying cause, using their physical exam skills that they learn in Ashley's class. And then we move on to decision making for lower limb orthotics. So sometimes I get a little bit of questions or complaints in my course of when are we going to start to learn about lower limb orthotic design? Like we haven't talked about AFOs yet, because we'll be several weeks into the course and still talking about gait analysis, finding the underlying cause, considering the patient's prognosis, et cetera. And little do they know that that is what makes up a lot of orthotic design are those background decisions. So teaching clinical reasoning is one thing, but testing it is another. I think we all have worked with different residents and students where, we've even heard comments like, residents either got it or they don't got it, right? In the academic setting, we can't just give people a thumbs up or thumbs down so subjectively. So we have to be able to test them on these skills. We can't just say, I don't think they understand lower limb orthotics. We have to be able to show through their performance that I think there's some misunderstanding here in your thought process. So, what that requires from me, the educator, is some oversimplification of the clinical reasoning process. But what this allows us to do is identify students who are struggling even under the simplest of circumstances. So, given the most basic information, can you make some of these decisions that should be relatively straightforward? If you can't, then we can flag you and try to help improve your clinical reasoning and try to figure out why you're choosing things that might actively be harmful to a patient or at minimum not really helpful given the information that was provided. If we make, in an educational setting, if we make cases, orthotic cases or prosthetic cases that are overly complex, then what you end up with is sort of the student has the ability to justify any answer that they provide, when in reality, there are some answers that are better than others. So in the classroom setting, we have to create that structure to identify people who are struggling. And we do that through one way we do it is through oral recommendations. And so by the end of the Lower Limb Orthotics 1 course, a student will be given this information on a piece of paper. We'll read it to them, and then they have 10 to 15 minutes to give us a full lower limb orthotic recommendation, which I'm going to show you here in just a second. So just to really pull back the curtain, I'm going to read you all this case, and I want you to think about what you would do. And then I don't know if we go over this exact answer, but we're going to go through a couple of cases so that y'all can kind of see how I teach clinical reasoning. And then I genuinely want to hear what issues you might think would come up in terms of teaching it this way. So, a 45-year-old patient with a family history of CMT presents with a prescription for a lower limb orthosis. They've used off-the-shelf carbon AFOs with a lateral strut for 6 years, but reports the device broke twice in the last 3 years, specifically at the strut near the ankle. While the AFOs help reduce trips and falls, the patient is seeking a more durable and comfortable option. On examination, manual muscle testing reveals bilateral dorsiflexion strength of 1 out of 5, plantar flexion 0 out of 5, with knee and hip strength within normal limits. The feet and ankles exhibit an inverted champagne bottle appearance due to calf muscle atrophy, moderate, partially correctable cavovarus deformity, and hammer toes bilaterally. The silver scoid test indicates limited ankle dorsiflexion with a maximum of 5 degrees dorsiflexion with the knee flexed and 5 degrees plantar flexion with the knee extended. Gait observation reveals a steppage gait pattern with frequent toe dragging and compensatory hip flexion during swing phase. The goals are improved durability and performance in their orthotic solution. So then we literally hit a timer and the student has 10 minutes to make a number of different decisions. And so I pulled a blank rubric that we use in my class. So the students have to make all of these decisions and verbally describe them to us within 10 to 15 minutes, kind of depending on where they are in the year. If it's earlier on, we give them a few extra minutes. If it's later on, we give them as little time as possible. So they have to decide on the side, which is kind of a give me, but you do have to indicate the side because you have to indicate it on your coding, and we do try to think about all of that stuff. These major decisions here in the design, they have to choose between custom and off the shelf. They have to choose the level of orthotic intervention. They have to choose whether it's thermoplastic, conventional, or hybrid, and then solid or articulated. And after that, they have to, based on whether they chose solid or articulated, they have different things that they have to complete their recommendation for. But out of these 4 categories, if they choose wrong on any of these 4 categories, they potentially fail their exam because these are what we've decided are critical design decisions where if you've gotten this wrong, we need to flag you as a faculty to see what was your thinking and what was your process in making these decisions and what information did you use to justify it. So they have to not only list what they want to do, but they also have to tell us the indication from the case. So what information from the case supports this decision? And then they also have to justify it by saying, I've chosen an articulated AFO because the patient presents with dorsiflexion range of motion within normal limits. And this is how an articulated AFO will benefit this patient specifically. So it has to be specific to the patient, to their ADLs, to their biomechanical goals, etc. And they have to do that for every one of the line items that you see. So this is really no easy task for the students, but they do all have to do this by the end of every single one of our core courses. So, a question for the audience, and I have my chat ready, is I want to know just off the bat, what are some of the factors that influence how you as a clinician make a decision between something custom or off the shelf, thermoplastic or conventional? You can kind of choose whichever one you want to explain here, and hopefully I'll be able to understand what you're explaining, or solid versus articulated. So you can unmute yourself or put it in the chat, but essentially, how do you all make these decisions? You don't have to explain it fully, but if there's one thing in your head or two things in your head that help you decide. Joe Terra said custom for triplanar deformity. Yeah, especially considering the severity of the deformity. Mark said custom versus off the shelf. I think there's more stuff coming there. Durability, orthotic history, failed device needing custom. Long-term use expected. Yep, and that's a justification that we have to have in our documentation. Size of the patient, deformities, activity level, atypical anatomy, single versus multiple planes of instability. I love all this. Anatomy, strength, specifically plantar flexors. Ooh, I like your answer, David. Yes. And then, these are all super related to like physical exam stuff, but do you guys have other stuff outside of sort of the biomechanical or anatomical need for that pushes you one way or the other for any of these? We have level of control needed. And I'm asking for the additional broader context because that's what we have the most difficulty, adding, to our cases where a student can understand the implications of that. Swelling or heat thermoplastic for thermoplastic versus conventional, activities and occupation. Exactly. And, other things that we have to consider are, again, patient experience or feedback, history of orthotic use, and shoe type. These are things that seem really little, but then when you actually start talking with a patient, what they're willing to use, exactly, Mark, cosmesis, shoe requirement, these have huge implications. But when it comes to actually teaching clinical reasoning, we try to stick to the biomechanical and anatomical reasoning that a lot of you guys were bringing up. And during residency, that's where that broader context can come in. Okay, so when I'm teaching students how to consider information to make these decisions, like I said, my philosophy in teaching clinical reasoning is to give them a biomechanical foundation. Consider normal gait, pathological gait, and your physical exam findings, and then make a decision. And then you can consider the patient's goals, insurance coverage, cosmesis, everything like that. So these are two very similar cases. And when I show these to the students, I don't necessarily put them side by side like this. They might get both of these cases. I have a document of like 10 different cases for them to practice with, and they're all kind of jumbled so that hopefully they can recognize the differences between the cases. But what you can see here on the left is that there's a 23-year-old man with an incomplete spinal cord injury that occurred 3 weeks ago. The student is given manual muscle testing, deformity presentation, and gait analysis for both cases. But then on the right side, you can see how I shift around some of the information to kind of push them, because what I'm trying to see is, can they recognize the indications for something custom versus off the shelf? That's all I'm trying to do in this case. So on the right side, there's a case written as it's an older 29-year-old person with a spinal cord injury from 6 years ago, with an MMT picture. They have a range of motion limitation, they have deformity, and we also have some more involved gait deviations from observational gait analysis. Sometimes in an exam setting, instead of telling them the gait deviations, we'll actually just play videos. So they have to also have the skill of visually assessing that, correctly identifying it, and then using the information. So what you see on the screen are textbook indications from ABC approved board exam references. So these are the indications and contraindications for an off-the-shelf AFO. So indications for something off the shelf could be that the AFO is only used temporarily, like in the case of a fracture or a tendon rupture. The person has to have only a mild deformity, mild to moderate weakness. They have to have full dorsiflexion range of motion available, and sensory function has to be intact. Contraindications for something off the shelf are patients with a moderate to severe deformity, limitations in ankle range of motion, severe weakness or gait deviations, a shape that falls outside of normal parameters, impaired sensation, or long-term needs. And this actually lined up really well with what a lot of y'all said in the chat. And the reality is as clinicians, we we sometimes follow these indications and contraindications, but there's always stuff outside of anatomy and biomechanics and gait deviations that pushes you to bend or break these rules, but you are doing it with a full awareness of what the implications are if you break any of these rules. The students receive an entire lecture on these indications and contraindications with a full explanation of why patients with a moderate to severe deformity are contraindicated for something off the shelf. So we take a lot of time to tease out all of these things, whereas most of you on this call are probably like, well, yeah, that's obviously indications and contraindications. But remember, we're starting with that novice level. So just to revisit the cases we just looked at, given these textbook indications and contraindications, the students will have studied those indications, contraindications. They'll look at this case and they have to describe to us the information to support a decision to choose something off the shelf. There's potential for change in that first patient. They only have moderate weakness. It's not severe. There's no proximal issues. They have normal range of motion, mild deformity, and intact sensory function. And then in case two, you know, your clinical presentation 6 years after your spinal cord injury is not likely without some type of major medical intervention. It's not going to suddenly improve. So we're going to need something that's more durable for long-term use, something that's you can manipulate the componentry to address significant weakness, both distally and proximally. And then there was a few other pieces of information. So that's ultimately what we're working up towards, and it takes a lot of time on normal gait, pathological gait, and physical assessment to get them making these decisions consistently and in a way that we can identify students who are struggling. So again, after a case presentation like that, they would have to provide all of that information. If they're providing a custom molded AFO recommendation, they have to be able to choose plastic thickness and type, inner boot, interface, modifications. We have them describe everything. Ultimately, they should be able to fill out a work order and code for what they are recommending to us. So now, I'm going through this process so that we can start to consider how learners apply this information during residency. Again, where we're getting them to is this novice foundation of skill acquisition. So they do have a rigid adherence to rules and they don't really exercise that discretionary judgment, meaning fully developed clinicians do know when I can well, I know that this is typically what I should do for a patient, but I'm deviating from my typical pattern of care because of this specific reason. And I'm also confident that how I'm breaking these rules. And so hopefully with experience with our patient models and clinical shadowing during the first year, our students can move into that a little bit, that advanced beginner, because they're going to start to get a broader sense of the situations in which you're applying these rules. And the other thing about being a novice or advanced beginner, so when you first get a postgraduate student or a Baylor student, um, it can feel like they're looking for a recipe or an algorithm or this oversimplified version of clinical reasoning, but that's because that's all they have to stand on right now. And it's our job during the clinical residency to help tease out and refine those algorithms in their head with all of the context we have from seeing thousands of patients. So residents, especially in the beginning of their residency, might still be acquiring situational awareness and learning what to prioritize. So if you look at that advanced beginner level, all aspects of the information, so all of the information often gets treated with equal importance. So they will find the plantar flexion contracture and the patient's goals as equally important. But as a clinician, you know that that's not always the case, that you through a medical history and situational awareness, you start to prioritize different things and then try to create an orthotic solution that's optimized considering that information. Residents should be moving into that competent level as well by the end of their residency. So they're coping with crowdedness, meaning their brains are crowded with information. They're crowded with the end of the quarter looming. They're crowded with the patient's goals. It's crowded with the gait observation. It's crowded with what I know this referral source really wants from me on a regular basis. Um, but there's a lot more deliberate planning and they have more routines, so they can start to tease out exactly what they should do, what is safe to do, and when they need to ask for help once they're in that competent range. The other difficult job that residents have is that they have to reconcile all of this information across each unique mentor they have. So whether you're doing a rotation-based model like at Baylor or you're doing a rotation model inside of a traditional residency, it is difficult for the resident to, I've learned how to make Sally happy. And now when I try to do exactly what Sally told me to do for this patient, Ashley's telling me that's not exactly how she's going to do it. And Ashley wouldn't do this, but Ashley might say, I have no idea why Sally told you to do that. This is a better approach. Um, it is not an easy job for the residents to make sense of all of that in their head. So just consider that if you get someone who is kind of just following the rules, they need to know the rules, but part of, I think, what a mentor can do is help them understand where the rules come from historically, and also when you and your experience have had to kind of not adhere to those rules perfectly. So it might help us to kind of just have a more formal thought process of how people kind of work through these levels of skill acquisition. So solid versus articulated decision making. These are the textbook indications for articulated AFOs, available dorsiflexion and plantar flexion range of motion, an anticipated change in function, or activities that are highly dependent on ankle range of motion, which it's hard to think of something that's not dependent on ankle range of motion. But contraindications for something articulated are moderate to severe contracture. And again, we as educators don't have ranges of motion that indicate mild, moderate to severe. And those are things that come up with students because they really want these rules. Is it plus or minus 5 degrees of plantar flexion that makes it moderate or severe? Like, when is it considered severe? And so we do kind of talk to them through these gray areas. And we also accept that at some point you just have to get more experience in seeing patients to kind of get that subjective understanding of moderate, mild, and severe. If there's moderate to severe spasticity present, severe triplanar ML instability of the ankle, and then severe muscle weakness are contraindications for articulated AFOs. And then indications for solid are contracture, significant hyper or hypotonicity, severe triplanar instability, and ankle pain. And then the contraindication from the textbook is if range of motion restriction would limit overall function. So not always super helpful, but this is what we're working with, and this is what we're using to prepare them. So I won't read you through these cases because we kind of already went through the exercise, but these patients are very, very similar. And so depending on how a student, if a student in my class provides the same intervention to both of these cases, I know that they are missing something in their clinical reasoning, and I can flag them and start to really think, okay, how can we help this student sort of, maybe they're not recognizing the important information, or they're prioritizing the wrong thing, or they just don't have the rules, the indications, contraindications well memorized, and that's what's tripping them up. But the one on the left is indicated for a solid AFO because they have spastic plantar flexors and a plantar flexor contracture. So when a student is going through there, we tell them, like, keep your design options loose in your mind until you can build a strong case for one decision over the other. And it's not always very clear cut, and we do give them, gray area cases on purpose to try to see, like, how nuanced is their thinking at this point in the semester. But case one would be more appropriate for a solid AFO, and case two is more appropriate for an articulated AFO. And there's more differences between these two cases, between a thermoplastic versus a conventional AFO as well. And so the student would be expected to identify those differences too. I think I doubled my slide, so I already talked about that. So what are the student opportunities they have to develop these skills in our courses? Our patient models, as I said, have real orthotic needs, and while we're tied to some of the standards to fabricate specific things, we do have many exam scenarios where there's a patient presentation, and they have to verbally give their prescription recommendation after they take a medical history and do a physical exam, etc. We also host an interprofessional education day with O&P patient models and Texas Women's University physical therapy students, where alongside a PT student, an O&P student, and a patient model from our program, they will come up with both an orthotic recommendation or prosthetic recommendation, and then also the PT students will come up with what they prioritize. And I think it's a really great experience for the students to kind of see the difference across even professions of how how the information is gathered, and then B, how it gets prioritized as well. So some of the takeaways for today are to just try not to, if you're educating residents or students out there, try not to underestimate how long it takes to absorb information that's completely new to you. So, even just thinking about, if you've heard of the Dreyfus model before, then you should ask Ashley and I out for a glass of wine, and we'll sit and talk to you about learning models. Um, but that's new information to you. So how much more would you need to hear about that to truly understand it, be tested on it, teach other people about it? It can take a long time to truly learn the complex nature of the job of a CPO. And I think it's easy for clinicians to forget because we've developed patterns in our brain and scenarios in our brain that help us simplify problems that are actually pretty complex, right? This is why, when we do AI activities in my class to see, like, what AI would recommend given some information, it gives you some wonky answers because it's actually a pretty complex problem with lots to consider. So let's try to remember that. Um, and a lot of what we bring into the patient room is our history of success and failure that we've had over our clinical career that drives much of our decision making. And sometimes it's like, well, a resident might ask, why did you do this and not that? It's like, well, I've tried it twice and it's like failed both times. And maybe that's just my own clinical skill is limited in some way, but some of that is driving our clinical decision making as well. So trying to talk residents through all of those different things. The actual bridging of the classroom versus the real world settings, I created this amorphous blob with a little expert triangle on top on the left there. I think sometimes that's what it can feel like to actually develop expertise and become proficient. But there are actual models of learning, there's models of skill acquisition that can help us, like, have the language to guide a learner through, and ourselves, not only the learner through the learning process, but guide ourselves through the education process as well. But I do want to point out that the foundation of the pyramid is still a rigid adherence to rules. We do have to start from somewhere, um, because if you are just diving in with no context, no rules, nothing to hold on to, It can be a very disorienting job to do, and the patients can suffer from that as well. So what these rules from the textbooks help us do are to make sure we minimize harm to the patient. And so if a novice at least knows the rules, they may not begin to execute them properly or things like that. But it does create a really strong foundation to then move through these different levels of skill acquisition. So what could you expect from a BCM student on the first day of their residency related to AFO intervention? And this is true of all of our core classes, but I was talking about mine. Um, a thorough medical history that's tailored to the diagnosis. So I'm picturing a scenario where it's like it's literally their first day, maybe it's their second day, and you're like, I want to see what you got. So there's an AFO eval on our schedule. I know what Baylor teaches you. Sally told me you'd be ready to do all of this stuff, so you're going to go do it. They should be able to do a thorough medical history that's tailored to their diagnosis and considers their prognosis, a thorough physical exam with priorities and major findings identified, observational gait analysis with the likely underlying cause, a general orthotic recommendation for the patient based off of that information alone. They have the technical skills to safely take an impression or a cast. They should be able to assess their cast quality, determine how to correct the cast, and identify what components they theoretically want fabricated for the patient. And then they can fabricate basic thermoplastic AFOs from start to finish because that's what is required of NCOPE master standards. So if a resident can do that, then in the context of this learning model, where can the mentor step in? In my mind, you can help them, if they can do a medical history and physical exam, you could help them identify the most important parts of the medical history and physical exam. They might be treating, like I said, they might be treating everything as holding the same weight, when what you heard when they asked the correct medical history question was like a major concern from mom about cosmesis, right? Or dad, whoever's at the appointment. um, that's where you can kind of guide them to help refine these skills because they do know how to do them basically. Same with physical exam. It's like, hey, let's figure out how to make your physical exam process faster, or you don't need to do these 3 different tests that you did. I know that they taught you that in school, but for this situation, it might not be the best use of your time. And here's why. You can help, again, refine their physical exam technique to get more reliable measurements and meaningful findings. For casting, you can help them refine their hand position, their speed, and patient positioning to get a better cast. And then you can confirm or refute their self-assessment of how they did, right? After you're done with your residency, it's just you in the room with the patient. It's you in the room with the patient with your prosthesis or orthosis, and you're deciding how well this all turned out. And that self-assessment piece is really, really important for the students and residents to develop. So how can we support specifically a resident's clinical reasoning development along this model of learning? You can ask them how they would address a problem or patient scenario based on where you're at right now. You know, a lot of young folks, I mean, I think we're all kind of nervous to be wrong in front of other people. Um, so, having that conversation with them like, hey, based on what you know right now, I know you're on your second week of residency, but based on where you know right now, what do you think you should do to address this patient's problems? Um, and in having that conversation with the understanding that they don't have the context that you have in your head of all of the years or potentially decades sometimes, um, ask them how they think, giving them new context because you were in there in the patient room with them or you know the patient. Ask them how they would think their original recommendation could change given the information that you are suggesting they prioritize, and then how to deal with all of that. And I think, in keeping with the theme of this year's CPD, I was trying to figure out how can we actually close the gap between the resident and their mentor. And I think this Dreyfus model, again, is just one model of skill acquisition, but it's kind of a way to think about how we can together move new learners through the process of becoming a CPO. So I'm happy to take other questions. We have about 10 minutes, but I know y'all all probably have to get back to patients and everything. Um, I would like to know, were you aware of formal learning structures before today, like the Dreyfus model? What are some strengths of the approach to clinical reasoning skill development that I presented? And then also, what are some limitations? Um, I have some idea of what the strengths and limitations are in my mind, but a lot of you are the ones that are out there training students and residents as well. So I would love to hear questions or comments. It can be related to what I have posted here or just something on your mind.
Holly, I have a question for you. So I think we can share with the group, and we have many alumni in the session today. One of the things we talk about as a faculty is the to to maybe use a little hyperbole, but the disaster that used to telling a novice learner, it depends. Like the answer of it depends, it that is not productive in any way. So how did you kind of work through moving away from knowing that you have knowing all the clinical context that you have, kind of focusing on the things they needed to learn?
Sorry, Ashley, can you repeat your question? Or was
Yeah.
it just a comment? Yeah.
Knowing the clinical context that you have and that, all of us on the call have, how did you kind of dial it down to avoid saying it depends?
Yeah, I think it was hard. It was hard. But I think making sure the way that I had to do it was I actually had to write slightly more straightforward cases and then allow that it depends conversation to come later in our curriculum once they're in residency and they have more context. Because now when they talk about accommodating plantar flexion contractures and shoe modifications, they've run into a dozen families who don't want to have shoe modifications. And so I think understanding, limiting my use of it depends on this and that, making sure that I understand what can realistically be achieved in the classroom versus what actually does have to be learned in the clinical setting, I think is kind of how, once I could separate those a little better, and it's still a little amorphous in my head, but once I could separate them a little bit better, I think it got a lot less. It depends. Jeremy said, just my opinion, but giving this presentation to your students may help give them context into the reality of progression from where they are to where they want to be. I think that's a really insightful comment, and it's something Ashley and I have recently talked about, formalizing some curriculum for the students to talk to, that meta analysis, talk to them about you got to think about how you're thinking and realize where you're at versus where you want to be. Sometimes they think they're a little farther than they actually are. And so maybe understanding what should be expected of them at this point would be definitely helpful. And I think we like anecdotally talk to them about that, informally talk to them about that, but a formalized curriculum would probably help them cope with the progression as well. Katie said, what you mentioned about describing mild versus hard really resonated with me. I find it also very hard to differentiate this to the novice learner. Do you have any specific tips? For example, at the foot, um, I find as many pictures as possible. Online, I have some pictures from patients that I've seen, and I try to show them. It's more so helping them understand what severe actually is. We actually have a couple of patient models that do have things like severe contracture, severe spasticity. And when we have opportunity to have the students interact with those patient models specifically to like experience that, we try our best. But the best I've been able to do is just scour different textbooks. Like orthopedic textbooks are good for finding lots of imagery of the foot, to really figure out what's severe. And then what also helps is during, oh, go ahead, Ashley.
No, I was just going to chime in, Sally. I think you use this as well, but to in the limited instances where we can quantify it, for example, with the foot and ankle, right? Using the foot posture index, right? Giving them some quantifiable tools to classify. Yeah.
Yeah, I agree. And I was going to say in physical exam, and in my class too, we do look at some measurable things. Um, but we're also aware that people, like, we're realistic about what everyday clinicians are doing in the office as well. And I think going through the physical exam course is very helpful because they assess each other's feet. And we rarely have someone with a severe deformity, so they get a good idea of like, look, you all have this much pronation or supination in your foot, and none of you sought out foot orthosis treatment for pain or for deformity. So I don't know if I have any direct suggestions, Katie, but I would say scouring textbooks for lots of different images. And, yeah, I would love an image bank of all of that stuff. Kim says, I was not aware of the Dreyfus model. It's a great depiction. Some limitations are the lack of formal textbook references to support all scenarios. Thank you for validating our struggle. The student tends to cling to wanting these references to understand how to do clinical reasoning properly without the clinical. Yes. Yes, I feel very seen, Kimberly, by your comment. This is something, again, I struggled with that when I first started teaching because it's like, oh, well, that's just what we do in clinic. And that is not a good enough answer for a Master of Science student. They do want the references. And so it actually brings up what I think are some good conversations about the importance of research to develop the evidence base so that we can actually start to have references um, for a lot of the very foundational stuff that we do. And so the opportunities for foundational research in O&P are just like ripe with opportunity. Like there's so many opportunities to just look at basic things like trim line placement and thickness and standards around that. We have standards, but they're not all necessarily supported by rigorous studies, as I'm sure most of you guys know. But to also too, I think to Kimberly's point, and then back to Jeremy's as well, I do think that formalizing the clinical reasoning process for the students and teaching them specifically about clinical reasoning could help them sort of understand that, like, look, we have these approaches, but we don't have references for all the rules, but you have to be okay with that if you want to progress your clinical reasoning. And here's how to kind of cope with all those differences. Any other questions or comments? I appreciate the conversation very much. I hope this kind of gave you some insight into how we sort of manage, the rules that are out there, breaking them. And I do tell the students, I'm like, what I want you to know are these rules, but I also want you to know them deeply enough to know what could happen if you break the rules. So, spasticity might be a contraindication for something off the shelf, but if you just still have to provide something off the shelf because it is still the best option, what do you need to consider? So that's my goal in terms of their clinical reasoning.
Thank you so much, Sally, for your
Of course.
presentation and your time today. Oh, we got another note
Yes.
in the chat
Clutch timing.
right before we wrap up.
The scale of mild to severe can be applied to multiple facets of the clinical presentation: alignment, skin integrity, pain, joint kinematics, osseous deviations, cumulatively leading to a clinical classification. Yeah. So we do classify that stuff across all types of domains. And that's a really good point. So there's for residents and students, there's constantly opportunity to kind of develop that eye for mild, moderate to severe. Wonderful.
Thank you everyone for your time. Thank you, Sally, for your great presentation. And we hope you guys have a great week.
Thank you, everyone.